Hello, my name is Professor Jerry Nolan. I'm a consultant in anaesthesia and intensive care at the Royal United Hospital in Bath, and it's a real pleasure to present for you this topic of airway management in cardiac arrest. These are my relevant conflicts of interest. I think the key one is that I was one of the co-investigators for the Airways 2 trial, which I will be mentioning during this presentation. This is what I hope to cover. We've got about 12 minutes, so it's a fairly brief overview. I'll cover the main randomized controlled trials that have been published fairly recently. I'll update you on in-hospital cardiac arrest, and then finish with some of the treatment recommendations that have been recently produced by ILCOR. This was a recent systematic review that supported the ILCOR treatment recommendations on airway management, and you can see this includes the controlled trials on this topic, and you'll notice that the top three are by far the largest, and these are the three recent ones that I wish to cover because I think clearly, based on numbers of patients alone, they're probably the most important. And in fact, all of those appeared almost at the same time, in the same year at least, in JAMA in 2018. So quite a lot of data there to cover. Just very briefly, I'm going to pick up these one at a time. This was the first, and this was the CAN trial. It involved out-of-hospital cardiac arrest, and it involved pre-hospital physicians in France and Belgium. And these patients were randomized to either a bag mask ventilation strategy, as you can see here, just over 1,000 patients, or a strategy of tracheal intubation first. Again, just over 1,000 patients in that group. And you can see here the primary outcome, 28-day favorable neurological outcome based on cerebral performance category 1 to 2. And basically no difference in those two groups, 4.3 versus 4.2%. But in fact, this was set up to be a non-inferiority trial. And actually, it was determined to be non-conclusive. Because as you can see at the bottom here of the slide, the lower confidence interval there was more than 1%, which suggests that they had not proven non-inferiority for that trial. I think two important things to say about that. First of all, these were highly skilled intubators, and their intubation success in this study was something like 98%. And you'll see that contrasts quite significantly with the other trials we're going to discuss. And the other thing to say is about 146 of the patients randomized to the bag mask group actually crossed over and received intubation, mainly because of concerns about regurgitation and threats to the airway. A couple of the other trials that I wish to discuss involve supraglottic airways, in particular the iGel and the laryngeal mask at either side of that slide. And these devices are clearly easier to insert. They require less training and less skills, and therefore may have some advantages in the context of cardiac arrest. This was the first study. This one is from the United States. It's the PARK trial. It was a cluster randomized controlled trial. The clusters were different EMS systems, as you can see in that top bullet there, and they essentially crossed over at 3 to 5 month intervals. They enrolled a total of 3,000 patients, and the primary outcome in this study was 72 hours. The reason being they did not have the funding to go for the more robust long-term outcomes. And the bottom line for this trial, as you can see here, primary outcome in the red box. This, perhaps surprisingly for some, showed a significant difference in favor of the laryngeal tube group for 72-hour survival. And in fact, the secondary outcomes, all the way out to favorable neurological outcome with an MRS of 3 or less, also significantly in favor of the laryngeal tube group. I think the critical point to make about this trial is that the intubation success in the tracheal intubation arm was just 51%. So one might argue that this result has come about because perhaps of the very low success rate in the tracheal tube arm, potentially harming those patients. The third RCT is this one from the United Kingdom. This is one that I was involved with. And you can see here 4 ambulance services. It was cluster randomized by paramedics, so each paramedic was randomized to either use the iGel or tracheal intubation. And although 4 ambulance services sounds like very few, that involves something like half of the ambulance services in the UK. The primary outcome for this trial was the favourable neurological outcome, as you can see here, MRS 3 or less, and there was no statistical difference between those two groups. Again, I've pointed out on the left-hand corner of the slide down here, the intubation success rate was just 70%, so somewhere between the PART trial and the CAN trial. So certainly not as high as one would like, and that's perhaps one of the features that has led to this most significant difference. So those are the 3 pre-hospital trials. Where are we with in-hospital airway management, or airway management for in-hospital cardiac arrest? There are as yet no randomized controlled trials for this. And probably the best observational study is this one. It comes from North America, it involves the Get With the Guidelines Resuscitation Registry. And basically what they did was to try and match up patients who were intubated within the first 15 minutes of the cardiac arrest with matching patients who were not intubated within the first 15 minutes. And they actually compared patients every minute in that first 15 minutes and used this sort of time-dependent propensity scoring system, a very sophisticated statistical way of trying to match up these patients. On the bottom line here, if we looked at the propensity match group, and you can see here just over 40,000 patients in each of these groups, but the survival to hospital discharge, which was the primary outcome for this trial, was 19.4% in those not intubated in the first 15 minutes versus 16.3% in those that were intubated. So significantly, therefore, in favour of not intubating those patients. So either there appears to be potential harm from intubation, or this is simply the result of residual confounders, despite the complex statistical methods used. This was a fairly simple observational study published fairly recently, just to point out that airway management in hospital is evolving pretty rapidly. This is a study from 5 centres in 4 different countries, and we can see here first, second and third airway management, quite a variety of airway management systems being used. And this is taken from this paper. These are Sankey diagrams, and they're showing patients that did not achieve return of spontaneous circulation on the left-hand side of the slide, and those not achieving return of spontaneous circulation. Yellow depicts basic airway management with bag mask and oropharyngeal airway. Blue is tracheal intubation, and green is the supraglottic airway. And these diagrams give you a very nice idea of the flow of airway management and the fact that they are essentially probably using a stepwise approach. The other thing to point out is that a significant proportion of those patients achieving return of circulation were managed with a bag mask only. And you can see that here because it stops at this point here. And that's significantly more here than on this side where ROSC was achieved. So we've got this potential stepwise, starting with very basic techniques, perhaps for a layperson it might even be compression only CPR with no air management, running all the way up to tracheal intubation. And in many cases, patients will receive all of those. I think interesting is the fact that some would argue actually that bag mask ventilation is potentially more difficult than use of a supraglottic airway. And that was certainly true. Comments made by physicians in the CAN trial often described great difficulty with bag mask ventilation and preferred, in fact, to go on fairly rapidly to tracheal intubation. So this is clearly a complex topic. Recommendations now from ILCOR, these will be reflected in a publication that will come out in October as well. Overall, we suggest using bag mask ventilation or an advanced airway during CPR for adult cardiac arrest. So that is really a very broad statement saying we just don't know which of these techniques is better. If an advanced airway is used, however, for out-of-hospital cardiac arrest, it needs to be basically, if it's in settings of low tracheal intubation success rate, the suggestion is to use a supraglottic airway. And if an advanced airway is used for out-of-hospital cardiac arrest in settings with a high tracheal intubation success rate, and I should say that the actual success rate defining high is not stated in this treatment recommendation, but many would believe it should be around 95%. So that's a pretty high figure. And if there is a high intubation success rate, the recommendation or suggestion rather is to use either a supraglottic airway or tracheal intubation. And then for in-hospital cardiac arrest, again, the suggestion there is either a supraglottic airway or tracheal intubation. And that is going to depend on the skills of the in-hospital resuscitators who are present at the time. So to pull all that together in summary, I think we've now got several randomized controlled trials, at least for out-of-hospital cardiac arrest, that are generally showing no difference in primary outcomes based on the airway strategy used. Clearly, it's going to be highly dependent on the skills of personnel, as I hope you've seen me highlight in those trials. I think it's very difficult to study this because there are often 2 or even more tiers of healthcare professionals attending these patients. And ultimately, a stepwise technique is often used where each patient will be exposed to more than one airway management technique. And then ultimately, of course, in the final bullet, it may just be that the method that we use to manage the airway in these patients has little impact on outcome. Ladies and gentlemen, thank you for your attention.